is pre-eclampsia. So before going on to pre-eclampsia, we'll discuss hypertension in pregnancy. So the pregnant women who develop or present with hypertension in pregnancy may be divided into chronic hypertension and gestational hypertension. Gestational hypertension. The International Society for the Study of Hypertension in Pregnancy it uses the term gestational hypertension for all the women who have hypertension in pregnancy with or without proteinuria. And if the patient develops proteinuria, it is preeclampsia. So here comes the classification. It is the gestational hypertension with or without proteinuria developing during pregnancy, labor, or puerperium in a previously normotensive and non-proteinuric moment. Number one is gestational hypertension without proteinuria. Number two, gestational proteinuria but without hypertension. And third is gestational proteinuric hypertension, that is preeclampsia. The patient has raised BP and proteinuria.
Because these pieces of information are important to identify and distinguish between various types of hypertension. So you have to emphasize and let that information sink in before you proceed further. Since you have given a summary, I would want you to repeat so that everyone is with you that what is gestational hypertension, or at what time if the blood pressure is raised, at what stages of pregnancy or before pregnancy, would it be called essential or chronic hypertension, and at what time of pregnancy, if it appears for the first time, then we will call it gestational hypertension. So are you with that? So thoda sa aahista karke, because the objective of this discourse, this discussion and presentation is that whatever is being said is also assimilated by the audience.
Okay. So we say that the patient has developed gestational hypertension if it's after 20 weeks of pregnancy. We'll discuss it later in the etiology of preeclampsia. So if the patient develops raised BP after 20 weeks, we say that the patient has gestational hypertension that can be with proteinuria or without proteinuria. If the patient has raised BP with proteinuria, it is preeclampsia. Then the chronic hypertension, it appears before 20 weeks of gestation, and it can be because of chronic renal disease, that is before 20 weeks of pregnancy. So the chronic hypertension may present without proteinuria. There may be chronic renal disease with proteinuria or without hypertension, and there can be chronic hypertension with superimposed preeclampsia, that is new onset proteinuria. Third can be unclassified hypertension or proteinuria, and fourth is eclampsia, that is a person has raised BP, proteinuria, and fits. So some basic definitions. Hypertension in pregnancy is said to occur if the diastolic blood pressure is more than 110 millimeter of mercury on any one occasion, or if the diastolic blood pressure is more than 90 on 2 or more occasions, but 4 hours apart. And proteinuria in pregnancy is said to occur if the patient has more than 300 milligram of protein in 24 hours urine collection, or if she has 2 clean catch midstream or catheter specimen of urine 4 hours apart with 2 plus of reagent strip. So we categorize the hypertension into mild, moderate, and severe. So patient is said to have mild hypertension if the diastolic ranges from 90 to 99 millimeter of mercury, and systolic blood pressure ranges from 140 to 149 millimeter of mercury. Moderate hypertension is said to occur if the diastolic blood pressure ranges from 100 to 109 millimeter of mercury, and systolic blood pressure ranges from 150 to 159. And severe hypertension is said to occur if the patient has equal to or more than 160 by 110 millimeter of mercury. So definition of
I am not with you.
Okay.
I am behind you. So I don't know about you.
Is it repeat for me, sir?
जनरली सिस्टोलिक पहले नहीं मेंशन करना चाहिए डायस्टोलिक से, जैसे माइल्ड है सिस्टोलिक जो है 140 190, बिकॉज हम सिस्टोलिक पहले करते हैं. सो माइल्ड में आप कहोगे कि 140 to 190 जो माइल्ड है, मॉडरेट वो उस तरह से है. एक्चुअली अब सिर्फ एक है कि रेज्ड ब्लड प्रेशर व्हिच इज 140/90 इज द लिमिट. अबव दैट इट इज 140/90 or above is raised blood pressure. that needs to be treated and addressed. And then severe is of course 160, 110 जिस तरह से आपने बोला कि वो उस तरह से है and above वो उस तरह से मॉडरेट दरमियान में हुआ करती थी, लेकिन आजकल इतना ज्यादा उसको नहीं देखा जाता। चलें, लेकिन ये एक तो सिस्टोलिक पहले बोलोगे और डायस्टोलिक बाद में।
ठीक। So definition of pre-eclampsia, it has 5 important points. That is the raised blood pressure of 140 over 90 millimeter of mercury. Number 2, there has to be 2 readings for if we label the patient as pre-eclampsia. 2 readings at least 4 hours apart. Number 3, that the patient has proteinuria, that is 300 milligram of protein should be present in 24 hours urine collection. Number 4, that it arises after 20 weeks of pregnancy in a previously normotensive person. And number 5, that it resolves completely by 6 weeks postpartum.
अब ये वाली चीज है ना, ये definition जो है, when you make a presentation, then you break this information into those 3 to 4, 5 pieces. So first is that hypertension, which is 140 by 90, and that must be recorded at least on 2 occasions with an interval of 4 to 6 hours. 4 hours आपने कर दिया, ठीक है. And then along with that, this is definition of preeclampsia. So one is that there is raised blood pressure, and that is in second half of pregnancy. That's what you are saying. In second half of pregnancy after 20 weeks. And then with that, there should be proteinuria, which qualitatively be 2 plus or quantitatively 300 milligram in a 24-hour specimen of urine. And then this is the blood pressure which rises on its own. There is no pre-existing raised blood pressure. And then the woman is known to be normotensive previously. And secondly, preeclampsia sometimes appears after the delivery. So this is the period starting from 20 completed weeks of pregnancy to 6 weeks postnatal, post-delivery or postpartum. So that is about say 20 weeks before and 6 weeks after delivery. So 20 weeks before the expected date of delivery or calculated date of delivery, and then 6 weeks. So over a period of 26 weeks, if it appears and it has this proteinuria, then it will be qualified as preeclampsia. And that emphasizes the need, particularly if you look at the last sentence, that emphasizes the need that those women, let's say priming gravida, someone priming gravida, twin, obese, or someone who is more likely, because I'm sure that you are going to tell us what women or what kind of pregnancies are likely to, or they are more predisposed to develop preeclampsia. So in those women particularly, even if up to delivery, the blood pressure has remained normal, then we need still to be on the lookout, and we must keep the patient, the woman, I wouldn't say patient, the woman under observation for 6 weeks for any signs of raised blood pressure. So the blood pressure should be checked from time to time.
Yes.
And this is something which we should tell. Now we don't do it. We generally don't do it. But this is a practical point that we should incorporate in our practice from now onwards.
Yes.
That in those women who are candidates for developing preeclampsia. A patient that I delivered on 9th of this month, she remained on 9th, she delivered on 9th. On 7th of September, she came for her checkup. She was a priming gravid, and her blood pressure was 110 by 70 on her last antenatal visit. On 9th, she came with leaking or something, and then we augmented her or induced labor, and she delivered on 9th. She had epidural, and after that she developed headache, and we attributed that headache to as an effect of or after effect of epidural, and the anesthetist they applied a blood patch as well. But during that time, it was assessed that she had developed some neck rigidity. And there was one reading of that neck rigidity was something else. But at that time, one reading of her blood pressure was 140 by 90, and she had traces of protein in her urine. Now, that, as a matter of fact, does not qualify as preeclampsia because you already said that It should be 2 plus, not traces. But it was a borderline thing. The point that I want to emphasize here is that a woman who has been normotensive throughout her pregnancy can have raised blood pressure, or appearance of proteins can be there in her even at the time of delivery or postnatally. So this is something that we all ought to be more careful about. चलें जी आगे.
So preeclampsia is a multi-system disorder and it involves placenta, liver, kidneys, blood, neurological and cardiovascular systems. And what are the diagnostic signs of preeclampsia? Those are hypertension and protein use.
As a matter of fact, since this is a multi-system disorder, but it is a disseminated thing because there is issue and problem with the whole vascular tree. And that will be even in the brain, you said neurological, everywhere, because this is a vascular or endothelial problem and issue there. Therefore, there is no system, no part of the body which is not affected by this.
Incidence, it occurs in less than 5% of an average antenatal population. And in primary gravida population, it is now said to occur as below as 2.2%. And the incidence of non-protein uric PIH is approximately 3 times greater. And the preeclampsia in women with a single risk factor is approximately 15%.
अच्छा ये हाँ देखो मैं इसमें this is something which we do not have studies over here of its prevalence or incidence, but we should have it. For example, in my private practice, I have not come across pre-eclampsia during the last 1 year. None of my those women who came with pregnancy, they delivered either normally or they had cesarean section, primary gravida or multiples. I don't recall any case of pre-eclampsia. Now, what it is due to, perhaps, this apparently falling incidence, as in the first line you say 5%, in the second line you say that now the recent studies show that the incidence is lower at 2.2%. Now, this is an overall incidence. If you look at the incidence in our public sector hospitals, or those women who haven't had regular antenatal checkup, or who have had other factors, socioeconomic, and they haven't been looked after that well in their antenatal period, in them, what is the incidence? We should know that. We need to calculate that. One of the factors probably is that we are using now low dose aspirin quite widely, and particularly in those women who are pregnant women who are candidates for developing preeclampsia, like those are obese, who have diabetes, or who have abnormal glucose tolerance test, or who are pregnant for the first time, or who have bad obstetrical history previously. We start low dose aspirin early in pregnancy. And now the trend also is becoming that around 16 weeks, you start giving them 150 milligram of aspirin. And aspirin has been shown, low dose aspirin has been shown to reduce incidence of preeclampsia by 62%. The rate of preeclampsia, and probably, since you mentioned that recent studies have shown the low incidence, it is now wider use of low dose aspirin that we start early on in pregnancy, which has probably reduced the incidence of preeclampsia. So we this would form a very good topic for someone to see, comparing patient population, say in a private setup and also in a public sector setup. That what is the incidence of those? If you have to follow that, it will be a very worthwhile study if it is, and I'm sure that it will be worth publishing in American Journal or British Journal of Obstetrics and Gynecology. But this is an important point.
Coming on to the etiology of preeclampsia, we first need to discuss what happens in a normal pregnancy. So during normal pregnancy, there's first wave of trophoblastic invasion that disrupts the normal spiral arteries of the mother, and it invades it and disrupts the internal elastic lamina and the muscular cord. And by the end of first trimester, all these changes have occurred. And in the second trimester, the second wave of trophoblast invasion occurs, and these spiral arteries are converted into mouth and sinusoids. And this high pressure, low flow system is converted into low pressure, high flow system, so that the fetal and placental needs are met. But in eclampsia, the second wave of trophoblast invasion phase 2 occurs. As a result, there is restricted blood flow to the fetal-placental unit and pre-eclampsia occurs.
Okay, yeah, now, if you look at these three diagrams on the left side, this is the normal, non-pregnant situation, in which the bluish area, light-colored area, is the uterine wall, and that, of course, that's convoluted thing coming down is the spiral artery of the uterus, which is present in the uterine wall, and there is no pregnancy. But when pregnancy occurs in the middle diagram, if you see that brownish thing, that is that again is that pool of blood or that area. But on the darker bluish and that area is invading trophoblasts, syncytial trophoblast and cytotrophoblast. And if you look, if cytotrophoblast is marked over there, that invasion really opens up and broadens the maternal vessels, spiral artery. So there is flooding of the blood in that area, and then the perfusion is greater. Whereas in the third diagram, if you see that level
सर प्लीज स्लाइड शो नहीं हो रही है. सॉरी सर, इंटरप्ट कर रही हूँ, स्लाइड शो नहीं हो रही है.
slide showing you ये दिखा. So there is the lack of that invasion of that extent of invasion is comparatively limited to what normally it happens, and therefore there is that the endothelial defect starts right here. So it is at the time of presentation that the issue starts.
यस प्लीज चेक करें, अभी हो रही है स्लाइड शो हो रही है?
जी सर हो रही है. जी सर हो रही है.
Here you can see that the genetic factors and abnormal syncytiotropoblast invasion, oxidative stress, they all lead to a defective placental invasion, and because of which there will be release of pro-inflammatory cytokines. As a result, there will be imbalance between the angiogenetic factors and anti-angiogenetic factors, and it will lead to the development of pre-eclampsia. In stage 1, there are natural killer cells, oxidative stress, and genetic factors that all lead to the impaired placentation and pseudovasculogenesis. And in stage 2, there are clinical manifestation of pre-eclampsia, that is IUGR, fetal edema, HELLP syndrome, proteinuria, hypertension.
यहाँ पे जो important चीज है वो even if you don't remember all the details of that, which probably is for the researchers for them. The factors are genetic factors, so there is a genetic predisposition, and then there is immunological factors which contribute towards that. Then there are couple of other factors, but here on the left diagram, which is stage 1, it essentially is how those genetic and immunological factors affect the placentation. So that stage is set right in the beginning, that there is comparatively a restricted amount of blood which is available, or blood flow in those areas in the placental area, and the placenta is kind of shrunk. And the clinical effects of those are given as if you look at the top of the second stage 2 diagram, that there is intrauterine growth restriction, and then there is those other features. Now, these are two new chemicals or hormones, which are, one is placental growth factor. This is always confusing. It appears to be PIGF. It is not PIGF. I is actually L, small l. So placental growth factor, remember that. And these are soluble FLT,
FMs like tyrosine.
Tyrosine like receptor 1, those things. I always kind of mix them up. So soluble FLT. Actually, as a matter of these are the chemicals which in the early stages of, if you measure them, these let you predict development of preeclampsia in a woman. So if you have to screen someone for preeclampsia, and all those women, screening starts actually with the history. So those women who are more likely to develop preeclampsia are candidates for preeclampsia. We'll come to that later. I'm sure you are going to tell us that. In those, this kind of screening would be helpful in identifying that these are the women who are developing these issues, and so that some corrective measures can be taken at that time. Again, so don't get unduly daunted by the chemistry and biochemistry of all that. Remember that there are genetic factors which predispose to women to that, and then there are immunological factors, and how they are translated is through these two substances. And I'm sure that with more research, some other substances also will come in light.
So as we have already discussed, that preeclampsia involves almost every system of the body. So in venous system, what happens is there's a lesion called glomeruloendotheliosis, and it is relatively specific for preeclampsia. It causes the selective loss of intermediate weight proteins like albumin and transferrin, leading to proteinuria. As we know that the proteins causes the plasma-on-cortex pressure, and when there is proteinuria, the plasma-on-cortex pressure will fall, and it aggravates the development of placenta. Here you can see that the membranes have become more leaky, more permeable, and there are less proteins. These both factors contribute to the development of edema. And the patient will have generalized edema. She can also have pulmonary edema and cerebral edema leading to seizures. That is eclampsia.
Now, these are actually changes which take place when preeclampsia is becoming severe. And therefore, in the recent accounts of preeclampsia, you will not see so much of emphasis on edema. One reason for that is that pregnancy is a state in which there is accumulation of fluid. So all pregnant women will have some degree of features of fluid accumulation, and dependent edema is one of the commonest that they'll complain of, that in the later half of the day or later part of the day, their feet swell and all that. And if you ask them that, what about in the morning when you get up? At that time, because they've been lying down and fluid redistributes, and so the edema is comparatively less. But if this kind of edema, which is there on hands, faces, etc., that should arouse your suspicion. So essentially, previously, preeclampsia used to be raised blood pressure, number 2, proteinuria, and number 3, edema. Nowadays, if you look at that, edema sometimes gets missed in description. So it is essentially raised blood pressure and proteinuria. But edema should be something which should be taken into consideration, and particularly if it is excessive. And it is not only pedal edema that one should be looking at, it's the rest of the edema, like pulmonary edema and cerebral edema. These are late stages. This is something which happens essentially in fulminating preeclampsia or imminent eclampsia, or in cases of eclampsia. So one has to be more careful about assessment of these areas when there is that severe preeclampsia. Fulminating preeclampsia is when it is so severe, when the general symptoms, general aura of the patient tells you that she is going to have a fit. So that is fulminating preeclampsia or imminent eclampsia. And these are the signs which may appear at that time. Not necessarily they are there all the time, because not all patients who have, or not all women who have eclampsia, they develop pulmonary or cerebral edema. But these are the progressive or features which can develop later on in eclampsia also.
So coming on to cardiovascular system, normally in pregnancy, there is marked peripheral vasodilation, but in preeclampsia, there is marked peripheral vasoconstriction resulting in
this you would see that right from the first trimester of pregnancy, when the women they complain of lightheadedness or fatigue or features of fatigue, etc. Not necessarily they are because of low hemoglobin or low iron content in their circulation. It is also one of the features of pregnancy, and that is because of fluctuating blood pressure. And the reason for that is peripheral vasodilatation, which normally happens in pregnancy. On the contrary, in a woman developing preeclampsia, there is generalized vasoconstriction because of the kind of vasospasm, and that results in raised blood pressure, reduced blood flow, which of course is in the initial stages of brain swelling and all that, but for the woman herself also, and the rest of the changes in the various systems. So remember that vasodilatation, peripheral vasodilatation is a normal. That's why women may complain of, a little bit of itchiness of the hands, etc., because of that vasodilatation. And that is the normal thing, but in preeclampsia, the reverse happens.
So there's loss of cell integrity resulting in greater vascular permeability and contributes to the formation of edema. In hematological system, in any event of endothelial damage, the platelets adhere to the damaged area, and if there is diffuse vascular damage, it is associated with laying down of fibrin. So increased fibrin deposition and reduction in platelet count in hemolysis can lead to the development of HELP syndrome.
And HELP actually is something which is more
severe form of preeclampsia,
but it can happen without preeclampsia as well, otherwise.
So in this case, the liver enzymes will also be elevated, and HELP syndrome is it occurs only 2 to 4% of women with the disease, and it can cause 60% of it can cause high fetal loss rate, about 60%. And the women with HELP syndrome, they present with epigastric pain, nausea, and vomiting. Why epigastric pain? Because the liver capsule is stretched, and it causes the right hypochondrium pain or epigastric pain. HELP syndrome is associated with a series of complications like acute renal failure, placental abruption, and stillbirth. So in neurological system, if the patient with preeclampsia has the convulsions, it is eclampsia, and there are retinal hemorrhages, exudates, and papilledema. Now here you can see if there is any local vasospasm to the kidney, the patient has the symptoms of oliguria and proteinuria. If the blood supply to the retina is compromised, the patient has blurred vision and flashing lights. And if the liver is involved, the patient has elevation of liver enzymes and which stretches the capsule and causes the right upper quadrant.
These are the features which we must take into consideration. You're working here in this private setup, and I'm sure that you haven't seen a case of eclampsia here. Even in public sector hospitals, the incidence of eclampsia is now much lower because of good antenatal or better antenatal than what it used to be previously. When I was training, or say 40 years ago, all the departments, they used to have eclampsia room. Eclampsia room was something which was said to be, there shouldn't be bright light. It was a rather dark area. It was secluded in a secluded portion, which would have certain facilities like suction apparatus, etc., and oxygen and other things, and the instruments for intubation if that was necessary. But gradually now we see that most of the departments, they wouldn't have a room of eclampsia. Initially or earlier, there used to be this viewpoint that the patient should be nursed in a dark room. But the disadvantage of that was that those patients who get neglected, they wouldn't. So it has to be a dark room, but there should be a bright light. There should be light enough. If there is a eclampsia room, there should be enough light. It should be close to the nurse's station so that there is a good watch over the woman, the patient, because she is sedated heavily, and just in case that she starts to have a convulsion or a seizure, then one would identify and know about that. Now, that's the extreme stage when a woman shouldn't actually have, if you are managing her properly, the incidence of a convulsion should be very small. Not necessarily that a woman with 160 or 170 by 110, 120 would have convulsion. Sometimes even a lower level of blood pressure could cause or result in convulsion. But what we need to be sensitive about, and what we need to keep in mind, is some of the features given over here, like right quadrant, upper quadrant pain, which is because of the stretch of liver capsule. blurred vision and flashing lights, if the patients complain of that. So if those are there, or heavy proteinuria and all that, then you start management right at that time and do not wait for a conversion to occur. You know, magnesium sulfate was introduced in America in 70s, and before that, magnesium sulfate came to be included in the essential drug list in Pakistan in 90s, not in 70s. So in 70s, when I was training at that time, we used to uh, 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 give these women sedation by various agents. I'm now forgetting even the names of drugs. Largectil was one of them. Uh, uh, I forget its generic name, Largectil. Then phenobarbital, pethidine. Those drugs are not even available. I'm sure that you people haven't heard. And there used to be a kind of circle that every 2 hours or 4 hours we used to give one drug and then the other and the third. And then in 70s, Jack Pritchard was the author, the main author of that paper, and they reported 75 consecutive cases of eclampsia without a maternal death or something. That paper came in, and then there were 100 consecutive cases and 125 cases. So they published quite a number of papers like that. And that was the point in which the rest of the world that also became aware of the utility of magnesium sulfate in not only preventing because in otherwise in cases of eclampsia maternal mortality was high. So magnesium sulfate was an effective anti-convulsant and also provided good sedation and good protection from the adverse effects of eclamptic fits. And therefore now, because of wider use of magnesium sulfate, that's probably also one of the reasons that we start giving magnesium sulfate as a precautionary measure for prevention of eclampsia. What you have seen here of administration of magnesium sulfate is to prevent neurological disorders of the newborn in premature baby or premature in cases of preterm labor. But magnesium sulfate dosage, you should know that 4 grams intramuscular or intravenous, slow intravenous is the loading dose. And then I am sure that you know the dosage and you will come to that of magnesium sulfate. But identifying features of impending eclampsia, right upper quadrant pain, blurred vision, and the flashing lights, and a compromised वो जो उसको क्या बोलते हैं जो क्या होता है sucrose the patient होता है ना going into kind of coma और वो level जो है हाँ वो वाली चीज उस तरह so if patient starts developing that, even if her blood pressure is not 160/110 or it's lower 150 100 or even 140/90 sometimes. So one should be aware of these features.
So how we manage the patient? We'll take a detailed history examination, do the relevant.
History तो वो तो patient है उसको इस तरह से हुआ हुआ तो history कहाँ से लोगे?
So risk factors for the
एक मिनट नहीं वापस जाओ मैं तुम्हें बता रहा हूँ. History, or if the patient is in such a condition, you see, ये याद रखो, in conditions like these, when you receive a patient who has had a fit or is about to have a fit or whose blood pressure is found to be like that, you don't sit down with her and अच्छा जी आपका नाम क्या है और आप कहाँ से आए हो किस तरह से उस history की जरूरत नहीं. These are the cases, these are the emergencies in which multiple things are being done at the same time. So it's a team thing. It's not one person who is dealing with the patient. And therefore you do not take history from the woman herself, the patient herself, but there are attendants who can give you that history if the patient is brought in that kind of situation. So you are taking history, and at the same time someone is looking at the airway, someone is putting in the Foley's catheter and securing IV lines. So all those multiple things. Similarly, if there is a woman who comes with heavy bleeding, so what do? you address those features first and start taking history or ask questions later. For example, securing an IV line, putting in an indwelling catheter, and ensuring that, of course, that she has an open airway. वो ABC वाली जो रूटीन है आप वो करते हो. So therefore ये वाली चीजें जो हैं जब आप in the context of severe pre-eclampsia अब यहाँ पे आपको मैनेजमेंट की साथ लिखने की जरूरत है कि मैनेजमेंट ऑफ प्री-इक्लेम्सिया बता रहे हो या जब आप वो लिवर कैप्सूल के बारे में बता रहे हो और उसको टोमेटा वाला बात बता रहे हो तो फिर लगता है कि आप उसकी ट्रीटमेंट बता रहे हो. तो देयरफॉर वन हैज टू आइडेंटिफाई दैट. प्री-इक्लेम्सिया वाला तो है वो तो एंटीनेटल में आइडेंटिफाई हो जाएगा. जो इक्लेम्सिया वाला है उसके लिए फिर ये है यू हैव टू शो in the postgraduate examination also, you have to demonstrate your ability to manage a woman who is going to have a fit or who is come in that situation. So what do you do? If you start with the usual thing, which is normal, this is the normal thing in the say cold case in which you take or you proceed to manage the woman or the patient in these manners, history, examination, investigation, treatment. But that is not the case with such emergencies. So you have to demonstrate your ability to identify that this is a woman who is in such a state and and how to approach her management. So this is to be, although you have written over there and you emphasize that these are the things that we have to do, but simultaneously and the management is.
Risk factors for the pre-eclampsia are the first pregnancy, the pre-eclampsia, any previous pregnancy, if the patient has 10 years or more gap from the last baby, if the patient is 40 years or more, if the BMI is of 35 or more, if the patient has a family, increases the risk up to 4 to 8%. And if the protein diastolic blood pressure is of 80 millimeter of mercury or more, so booking protein urea of 1 plus multiple pregnancy and certain underlying medical conditions like chronic renal disease, chronic hypertension, SLE. So
those conditions which lead to vascular issues.
So investigation. To monitor the complication, we need to do CTG. We know that pre-eclampsia is a risk for placental abruption, IUGR. So we'll do ultrasound to assess the fetal growth.
Rabia, it would have been better if you would say maternal and fetal को अलग करके ना वो उसमें कर लो. ये वाली जो चीज है.
So for ultrasound, we'll do for fetal growth, amniotic fluid, and Doppler for umbilical artery waveform. Full blood count for the platelet count and rising hematocrit. If the platelet values are normal, we do not need to do the coagulation profile. We'll do the RFT and LFT and serum uric acid and urine for protein. So how will we manage the patient with pre-eclampsia? If we have mild to moderate hypertension, then we'll admit the patient. If there are any clinical concerns for the well-being of the baby, the decreased fetal movement, or if the patient has headache or any symptoms of pre-eclampsia, we'll offer the anti-hypertensive pharmacological treatment if the BP is more than 140 by 90, and we should aim the BP should remain 135 by 85. And if the patient is admitted in hospital, you can do more frequent monitor of BP. Otherwise, it should be done at least every 48 hours. And deficit protein urea testing is only clinical. If it's clinically indicated, then we will repeat it. Blood test, full blood count, our LFTs and RFTs are repeated twice a week. And fetal assessment at every antenatal appointment, we'll do fetal heart auscultation and routine ultrasound every 2 weeks if it's normal, and carry out CTG diagnosis and then only if clinically indicated.
इसमें अगर आप वापस से आओ ना, क्योंकि अभी तो आपने यहाँ पे जो है मैनेजमेंट में तो आप इसको इस तरीके से बोलोगे. अभी तो it appears that patient is admitted in the hospital, right? अगली स्लाइड पे जाओ तो आपने फिर घर भेज दिया. तो कब घर भेजा कब किया इसको थोड़ा क्लैरिफाई करने की जरूरत होगी. So If it is 140/90, it is, as you said, mild preeclampsia, then you provide treatment and you keep the patient under observation. So what generally one would do is that you increase the frequency of antenatal. Now, if she is coming after every 4 weeks, since say is around 24, 28 weeks, if you find that, maybe you would want to call her after 1 week. Or if the facility is available and the woman can have her blood pressure monitored at home, you can instruct her that this is how you have to monitor your blood pressure, and you do that. And if it rises above this level, then you report. Or if you have your urine tested, how frequently, every second day, every third day, and this is what needs to be assessed in that. And if you develop this, then you report. So then there should be you said that admit any clinical concern. Yes, moderate to severe, they have to be admitted for monitoring. And if the blood pressure then comes down to that level, 135,
Right.
85, and if it comes to that and there is no proteinuria, then you send the woman home. And with the instruction that again, monitor blood pressure like that. Or second consideration is, one is blood pressure and proteinuria. Second consideration is the duration of pregnancy. So this is something that you will be doing in say 28, 29, or even 30, 32 weeks pregnancy, and which is early preeclampsia, which is not late preeclampsia. So preeclampsia can happen in later weeks, around 35, 36 weeks. But if it happens earlier at that time. Now, in those women, what do you do? And then, if they are close to term, then having assessed that, you see, calling them every 2 days, calling them every 3 days, because at that time, normally you would call them every week. So you call them more frequently, or keep them admitted. The considerations in the hospital would be whether you have enough beds, what is the level of seriousness or severity of the disease, and according to that, you keep the patient admitted or you let her go home. So those are the things which need to be said. So if it is mild preeclampsia, you increase the frequency of antenatal and ask the woman to monitor that if facility is available. If she is close to the hospital, she can be called more frequently, and with clear instructions at what on what features and symptoms she needs to come to the hospital. And if it is moderate to severe, the woman has to remain in the hospital. And you have also mentioned here in the second row and second column, full PIRES and PrEP as risk prediction. Do you know that?
सर ये मैंने पढ़ा था, मुझे याद नहीं है। एक
अच्छा,
मैंने
एक मिनट, मैं आपको जरा इसका ये बता दूं, एक मिनट ठहरो। Let me get it. This is something that you get on net.
Yes sir, तो नेट में वो एक नहीं खुल रहा था।
एक मिनट, मैं अभी प्रपोज दिखाता हूँ। ये फुल पायर्स, ये है। मैं जरा स्क्रीन शेयर करने लगा हूँ। ये इधर से स्क्रीन शेयर कर लूं मैं? यस, हो जाएगा। दिस विल स्टॉप अदर स्क्रीन शेयरिंग। मैं वो कर रहा हूँ अभी।
हम स्टॉप कर दिया।
हाँ, ये अभी तक उधर से उसका उधर से स्टॉप करेंगे। You see, this full PIRES is pre-eclampsia integrated estimate of risk. PIRES जो है, pre-eclampsia integrated estimate of risk RIS उसको उन्होंने वो किया हुआ है, वो मैं अभी दिखाता हूँ आपको स्क्रीन पे। तो आपकी स्क्रीन आ रही है, तो उल्टा काम हो गया, कुछ और आ गया है इधर। ये आनी चाहिए स्क्रीन ये तो स्टॉप हो गया मेरी। अरे उधर से स्टॉप कर दिया आपने? पार्टिसिपेंट्स कैन नाउ सी योर स्क्रीन। चले एनीवे आप ये है एक साइट है एविडेंसियो, आप नोट कर लें EVIDENCIO एविडेंसियो। You go onto that and then it usually will give you full fires full को छोड़ दीजिए, तो बाकी fires जो है P stands for preeclampsia, I for integrated, E for estimate और जो RS है वो है risks, RIS ले लिया risk। So preeclampsia integrated estimate of risk. If you scroll down, you will find that there is a kind of pro forma given in which you give the gestational age between 20 to 43 weeks. For example, I'll write here 37, choose a value between that. Gestational age and days, 37 weeks and 4 days, right? Chest pain or dyspnea, no. Platelet count, I'll write here 128. Creatinine, I'll write 0.9. Choose a between 1 and 30, all right. Millimoles, that's different. I wouldn't know how, all right. We will say 45. Aspartate transaminase, it is not really raised, I'll say 32. Oxygen saturation is 98. The risk of adverse maternal outcome is 1.7%. So this is how it is done. This is the kind of graph which is given here, and you fill it in and give those values of the patient, and it gives you the risk of adverse maternal outcome is 1.7%. Now, if you change here, for example, you change the creatinine to 200, and then the risk is 3.5%. So you change one parameter, which may be, or let's reduce the duration of pregnancy to 32 weeks. If at 32 weeks she has these parameters, the risk of adverse maternal outcome is 4.5%. So it varies with that. And this is how you use this. This is not something which is available. You could have probably an application on your phone as well, and you can access it on your phone, but you have to fill up these. And the second one, PrEP as risk prediction, that's also more or less the same, and that's also given by this Evidencio. So Evidencio is the site on which, if you provide this information on on Google. Full Myers, this department of certain obstetrical unit, but you go on Evidencio and it is available for everyone. Background, method, findings, interpretation, and then downwards you calculate that. So this is how you calculate in these cases the risk assessment of the women. Well, that's important, and you should know about this and how to do it.
Next slide, please.
Sir, how much percentage is considerable for the admission?
That I am not sure about, but that just shows that the risk is there. That is so much, and therefore you have to be on the watch. Just now we changed some parameters, and you must have heard about that. For example, when I said that there were certain values at 37 weeks and 4 days, and with 200 millimoles creatinine, the risk was 3.5%. But if all that happens at earlier age, then the prognosis is poor. Then it became, instead of 3.7, it became 4.5. So that means that there is some urgency, and you know, the bottom line for management and treatment of pre-eclampsia is there is just one word, which is delivery. Deliver the baby. So if you deliver empty the uterus, then the stimulus for and the aggravating stimulus as well as the aggravating factors for that problem, that goes away. And therefore, if at 37 plus weeks, when it is full term, not premature, then you can go ahead. And it is not only the maternal thing. Maternal thing is one, but it's also the benefit or the status of the fetus. If that is not doing well and its well-being is compromised, then you decide for the optimal time. So far, we have discussed only the impact on the mother and how serious it can be for her and what we need to do about that. But I'm sure that, like in the next slide, the way नहीं इससे पिछली हाँ इससे नहीं यहाँ इससे हाँ ये वाली यहाँ पे fetal assessment की बात हुई. So the maternal situation, of course, gets worse with the preeclampsia getting severer, but it is also the fetus who suffers from that because of compromised circulation, and therefore you have to strike a balance between maturity of the fetus and the maternal condition. But if she has severe preeclampsia, then you would forget about the fetus and then you will only look after the mother. So वो उस लिहाज से इस तरीके से है. That's how you go about it. And well, the risk prediction is, अगर आप इसको डिटेल में पढ़ेंगे तो फिर वो है यहाँ पे ये दिया हुआ interpretation. The full Myers model identifies women at increased risk of adverse outcome up to 7 days before complications arise, and can thereby modify direct patient care. For example, timing of delivery, place of care, because you want the baby to be born in a place where there are good neonatal facilities. Improve the design of clinical trials and inform biomedical investigations related to preeclampsia. So this gives you the adverse outcome. The prediction is that how soon or late those adverse effects are going to come into play. कितनी स्लाइड रहेंगी? 12. मेरा ख्याल है इसको फिर हम बाकी we'll continue next time. Okay. और ये इसको जितना आज बताया गया है इसको जरा अच्छी तरह से खुद से जाके पढ़ें और देखें इसको. ठीक है, चलो. Thank you very much. Good, Radha.
Thank you.
Very good. Yeah. और कोई any questions from the audience?
सर एडमिशन भी सर सीवियर प्रीएक्लेम्पशिया में एडवाइजेबल है ना? एडमिशन जो है पेशेंट
बताइएगा जी.
Admission का पूछ रहे हैं सर, advisable है pre-eclampsia?
Yes, of course. You know, this is something which one of the examiners asked me in my LCPS examination. That what is the limits? मुझे उन एग्जामिनर की यूनिट का पता था, उनकी रूटीन का पता था. ये वो उस जमाने में बड़े एग्जामिनर भी कम होते थे, कैंडिडेट भी कम होते थे, चल रहा है. तो वो इसलिए मुझे पता था. मैंने कहा जी, I know there are very good units, but they are cramped for space. There are limited number of beds, and there are 2 patients on one bed. But the facility where I work, we have plenty of beds, and therefore we admit patients at a blood pressure of 140/90 and proteinuria test traces. तो बिकॉज मैंने उनके यूनिट में देखा हुआ था, वो वहां पे उस पे नहीं एडमिट करते थे, तो हम उस तरह से एडमिट कर देते। शी वाज वेरी हैप्पी विद दैट आंसर। सो इट डिपेंड्स अपॉन दैट। जिस तरह से आप व्हेन इट इज लाइक दिस, इन अ केस ऑफ प्लेसेंटा प्रीविया, major degree placenta previa, who presents at 32 weeks with bleeding, and she has been admitted for a couple of days and the bleeding has subsided and she is all right. What do you do? Do you keep her in the hospital till her delivery, till the cesarean section, or do you send her home? There are various factors. How far does she live? Is transport available? How soon can she come to the hospital? Issues like that. So if that is there, then you will discharge the woman home and tell her that all the time you should have availability of transport. This is something that you will not do. This is something that you do, and this is how you come to the hospital. But if someone is these days, even placenta accreta, we send home and do not keep them admitted for say 6 weeks. Now, in this patient, because the outcome can get worse. And as I said earlier, if the blood pressure is in the range which is below what has been said to be moderate preeclampsia, then I would send the woman home and ask her to monitor blood pressure, check for proteinuria, and if it gets worse, then come to the hospital. If it is moderate, I'll keep her in the hospital till her blood pressure is brought within the acceptable range and her urine is clear. Only then will I send her home. Until she has proteinuria, she has a blood pressure of 150 by 100 or 110 or more, I'll keep her in the hospital. Also for the sake of the baby. So I would keep a moderate preeclampsia woman admitted in the hospital.
Sir, and what about the dipstick in the hypertension category of the preeclampsia? It is done once a time in the in our OPD. The every visit we do the dipstick. What should we do?
The dipstick tested, we do it every visit, on every visit.
Actually, in a good antenatal care protocol, urine must be tested on every visit, even in the first half of pregnancy. Generally, every 4 weeks, if you do the test, that is better. That is what used to be done previously. In my private practice, I don't do it. I do it on the first visit. I do it around 16th week, then around 24 weeks, then 32 weeks, and then later. So that is our routine in an uncomplicated woman. But if a woman has raised blood pressure, then the urine has to be tested and on every visit. ठीक है जी, चलें बाकी क्वेश्चन संभाल के रख लें, फिर हम नेक्स्ट वेडनेसडे इंशाल्लाह हम ठीक है। ओके, थैंक यू।
गुड मॉर्निंग सर।
अस्सलाम वालेकुम जी।
क्या हाल है?
ठीक ठाक जी।
तू ये जे लेक्चर लेने ना तभी तेन वो रिटायर्ड नहीं समझते।
हाँ, मैंने रिटायर्ड नहीं समझते
है ना, क्योंकि उन्होंने क्या जड़े रिटायर उन्होंने वो 60 का लफ्ज नहीं इस्तेमाल किया। उन्होंने क्या जो रिटायर्ड ने उन्होंने उसे वीजा देवांगे, जेडे नहीं रिटायर्ड उन्होंने नहीं वीजा देना।
उन्होंने नहीं वीजा दिया, उन्होंने रिटायर्ड नु देता,
उन्होंने रिटायर्ड नु देता। हाँ,
थोड़ा पासपोर्ट चला गया,
किथे चला गया है।
हाँ,
मैं प्रपोज कर रहा सी हुणे यूसुफ नु
हाँ,
कि मैं लुबनान टेलीफोन करांगा लेक्चर तो बाद 10:30 11 वो जाग ही गई।